Good morning. First, I would like to thank the organizers to invite me for this excellent meeting. And I hope that my presentation, being not about the pancreas and the training, will also be interested for you. So we are facing, all of us, in the increasing number of elderly patients with different diseases, and also the problem of treating the liver tumors in elderly patients. In the 70s and 80s of last century, the operative mortality for patients undergoing hepatic resection, major hepatic resection, was reported as about 1% for younger patients and more than 10% for patients older than 65 years. In the same period, the operative mortality for older cirrhotic patients was reported even higher, as 30%. And in more recent studies, what we can read now is the oldest age is a prognostic factor of in-hospital mortality after liver resection. And mortality after this resection in elderly patients has the complication rate of about 6 to 8%. And a recent American study of ORCAD, which was based on almost 1,500 patients, were elderly patients, found the mortality lower, about 3.3%. And we shall remember and consider that our elderly patients have a shorter life expectancy as a result of mainly of comorbidities and their advanced age. And for them, quality of life and recovery is more important. Coming back to the American study of ORCAD, age over 75 was associated with the increased need of transitional care after hospital. And however, also it was associated with the comorbidity index, so we are really not sure if it was the age only or the comorbidities too. And overall low postoperative mortality rate observed in these patients supports the use of liver resection, active treatment of liver tumors in this patient, but when they are appropriately selected. So let's look at the primary hepatic carcinoma Japanese experience. Before 1990, the median age of primary hepatic cancer patients was about 60 years, and 20 years later, in 2010, it was reported as 71. And tumors were more advanced in the youngest group, but of course, the survival was worst in the oldest group. However, we shall consider that elderly patients survive for the highest percentage of their life expectancy after receiving an active treatment for hepatic malignancy, primary hepatic malignancy. So authors conclude that the age should not be a contraindication for active treatment of primary liver neoplasm. Let's look at the clinical practice for more common disease like secondary liver neoplasm. In the studies reporting natural history of colorectal liver metastasis revealed that even half of all patients presenting with liver mets were older than 70. However, in studies about the treatment of colorectal liver metastasis, only up to 20% of patients were older than 70 years. So this difference may reflect a process of selection of patients favoring for older patients palliative treatment or even supportive care. Another option for the treatment of liver tumors is radiofrequency ablation. And when we look at some data, there was no difference between hepatic resection and radiofrequency ablation in patients with small primary liver cancer, which was smaller than 3 centimeters. So results were equal. And but the other reported that in the general community, patients treated with radiofrequency ablation have a similar risk of adverse event to those treated with hepatic resection. But it was general community. The difference is in specialistic centers which are familiar with the technique of radiofrequency ablation. And in those centers, the number of complications, the risk of complication is lower for radiofrequency ablation than for hepatic resection. What are the guidelines for radiofrequency ablation of a liver metastasis, liver tumors by National Institute of Health? So it may be indicated as a primary treatment for patients who are unfit for surgery in the treatment, primary treatment or the recurrence post-resection. It also may be used as an adjunct to hepatic resection to treat a small fucus, a small lesion in a remnant liver. So I would like to present a series of patients from our department in Krakow treated for liver focal lesions. There were 813 patients treated between 2005 to 2014, and the median age was 62. Looking at the structure of the age, 43% were older than 65 years, and the rest, 57%, were the younger group. Looking at the structure of the groups, we can see that there were 100 patients who were older than 75, and 253 patients who were between 65 and 74. What was the diagnosis? This were not only malignant tumors, but in an older group over 65, the primary liver neoplasm was 90 patients, secondary, so metastasis, 239, benign tumors, 17, and other 7. So this group consisted of 353 patients. And the younger group, it was 61 primary liver neoplasm malignancies, secondary was 309, benign 56, and other 34. So this group was bigger, 460. So looking at the distribution of the diagnosis, we can see that in an older group, it was an increased percentage of primary liver tumor and similar percentage of liver metastasis, but the percentage of benign lesion was lower. So what were the procedures for those patients? For the older group, resection of 1 to 2 segments was performed in 41 patients, resection of more than 2 segments, so 31, and non-anatomical resection 50, and radiofrequency ablation in 215 other procedures like drainage in 16 patients. In the younger group, the procedures were similar. However, we can see that the group was bigger and the number of radiofrequency ablations was smaller, so rather more aggressive strategy. And the distribution of procedure is that we'll clearly see that more radiofrequency ablations in the older group and other procedures were similar, but there was, except radiofrequency ablation, the difference was not significant between. But the main thing is, what was the outcome in these patients? But because, of course, we can do anything, but the interesting thing is the outcome. We'll look at the safety of a procedure. So the length of hospital stay in resection cases was slightly longer in patients in the older group. It was 12.3 days compared to 10.4 in younger groups. And 30-day postoperative mortality was about 1.5% in younger, 1.7% in the older group, and the major surgical complications were 6.6 in the younger, and the lower rate 4.1 in the older group. But there were no statistically significant differences. And the similar results are in radiofrequency ablation. So there was no difference in the length of hospital stay and 30-day postoperative mortality and the major surgical complication between those two groups. In conclusion, I'd like to say that in the older group of patients, there was an increased incidence of primary liver neoplasm, which is in line, for example, with the Japanese experience. And radiofrequency ablation was more frequently used in older patients. And the resection and radiofrequency ablation had similar outcomes in both groups. And the perioperative risk is acceptable in older patients. But these results are the effects, of course, of patients' selection and the treatment adjustment to the age and comorbidity. Thank you very much.
Thank you, Professor Antoni. Any of the audience have any comments or any question? Yes, please.
Hello. Thank you, Dr. Antoni. I just wanted to ask about any significance of TACE adding with RFA, like transarterial chemoembolization before going for this robotic knife or radiofrequency for the tumors.
I couldn't understand it very well.
It's an intraarterial chemo. It's an intraarterial chemoembolization for the tumors, liver tumors, HCC, before going for this RFA. The downgrading of the tumor size.
So you think the criteria for radiofrequency ablation?
No. I just want to add.
Chemoembolization before the RFA.
We rarely use the chemoembolization in our center. So there were a few patients who were chemoembolized, and that's why I didn't analyze it.
Because we have in India with some centers, with some series in which we are going and giving the chemoembolization, rather we are embolizing the portal vein, the part of the portal vein also. And after that, the downgrading of the tumor or the tumor size, because once the chemoembolized tumor, if you go for again the MRI findings, it becomes a solid organ, solid lesion. And then when we give the radiofrequency, the effects are very good.
So, of course, as I said, we can chemoembolize rarely. So, of course, it's a valuable method to do it.
Thank you, sir.
Thank you.
Tony, thanks very much. Really enjoyed that talk. Can I ask a question? How old is too old frequently now I'm asked to see patients who aren't fit for FOLFOX or FOLFIRI, but I'm asked to consider them aged 83 for an isolated MET or low volume disease or something that we can address laparoscopically. How old would you go, and do you do any preoperative screening on these patients that is specific to your unit?
That's always a question. Who is too old? And the oldest patient in this series of patients was 84. And but the metrical age is not an indicator. So in patients who are over 70, we are, of course, trying to do all necessary consult and also a battery of tests which are specially prepared for elderly patients. And if this the performance status of a patient is good, so we can't say it's too old. Sometimes we can say it's more the status and the comorbidities that limited us than the age. Of course, we also look at the life expectancy, but 80, 82, 85 isn't too old for example, radiofrequency ablation if the general condition is good and the life expectancy is longer than a year.